So about the FDA approval, you were part of the Navigator study as I was, and I wonder what you think of, we've seen the response rates. What do you think about the durability of response? Do you think that it's the real deal?
I think it is. I think it is. The median duration of response wasn't reached in what was reported in those 42 patients. So it is definitely even the duration is quite long. The patients derive benefit from. We can talk about, and this drug is so sensitive for the D842V mutant patients that actually they do well even on a lower dose.
Yes,
because quite often this drug does require, dose modifications. But thankfully, because of sensitivity, I'm quite quick to dose reduce for the PDGFR mutant patients, and they do well, long term. Yeah.
Many have compared this drug to our first use of imatinib in the very early clinical trials, phase 2, phase 3 trials, where we had KIT mutant GIST patients that had never been treated before, and imatinib was introduced, and it was this huge home run because pre-imatinib, the overall survival on median for a GIST patient was 9 months. Now there's data suggesting that GIST patients, when metastatic, may be surviving 7 years. And I'm sure you have some in your practice that have had metastatic GIST for almost 2 decades.
Right. They were some of the first people who got imatinib way back in 2002.
Yeah. So I think avapritinib is going to be analogous. I think we are going, as the data unfolds over time, we're going to see this agent impacting patients' lives in an incredibly meaningful way.
Right. And when you think about, just as a thought, with the PDGFR patients, what do you think their natural history is? Because, when I'm treating these patients, before avapritinib was approved, some patients do have a more slow progressing trajectory than some of the KIT mutant patients, and some of them, of course, progress really fast. But the way I'm seeing it, both those populations seem to respond really well to avapritinib right now. So what about the side effects, though? We just kind of briefly touched about the dose reductions, though. What are the challenges you have faced, or is most prominent to you with avapritinib in GIST patients?
Yeah, I think that's a very good question and very important. As I said earlier, with any of these agents, whether it's targeted therapy, immunotherapy, chemotherapy, there are going to be side effects. No agent comes with no side effects. So the side effects that I commonly see with avapritinib include many that are similar with other TKIs, like there can be some fatigue, there can be some nausea, there can be a little bit of loose stools, soft stools. Those are largely manageable. There may be some laboratory effects. You might see decrease, maybe a little bit in hemoglobin. But they're all fairly mild, manageable. Hand-foot syndrome's fairly rare, especially compared to sunitinib or regorafenib. The one thing I think that we're still discussing is the cognitive effects that we've seen on the clinical trial. Seems to be very rare. It seems to be a small percentage of patients, but it does seem to be real. And what I've seen with my patients is sometimes they might be a little forgetful, not remember where the keys are. They might have a little difficulty sometimes with word finding. So I think those are the issues that I have seen in a small percentage of patients, probably single digit. And the way I've managed it is I've held the dose usually until the symptoms clear up. And then I usually dose reduce. And that's been my approach to management of the cognitive effects, and it's been, at least in the patients I've treated, it's been pretty successful.
Yeah, and I think it's good to point out, I think, when they reported close to 50% CNS abnormalities, it was with the higher dose with the initial phase 1-2 study. So with the higher dosing, there was just a higher rate. And again, I think the challenge has been not being able to define it well, and they put into that bucket the CNS hemorrhage that they saw, which is rare, but that's something to watch out for. People did have CNS bleeds. But what you're talking about, the memory impairment, has been difficult to quantify, so to speak. And I think with the dose of 300 milligrams that was finally selected, it actually is less common. But I think we still need to figure out a way to follow these patients to pick it up so we can do those dose reductions early so it doesn't become a big hindrance to their quality of life. In your practice, are you doing any kind of testing for their mental status before you start?
That's a good question, very good question. And I'm not doing baseline neurocognitive testing.
Right.
So, but I do work with our neurologists and our neuro-oncologists. If I see any symptoms at all, or if a patient's spouse mentions any symptoms at all, we do have a referral to neurocognitive testing by our neurologists, and we have a neuro-oncologist who specializes in neurocognitive dysfunction from systemic therapies, and so they do a full assessment. And importantly, they rule out other causes, because there can be other causes, other types of, for instance, unmasking in Alzheimer's disease or other dementia. So they do evaluate for other causes and then optimize the patient's care. And that's how we monitor. But I think part of monitoring is not just asking the patient, it's asking the spouse or other caregiver, family members who are living with the patient day to day.
Correct. And I think as we get more data, we'll learn maybe it's higher propensity in the older population, but we don't know all of that yet. And as you mentioned, anemia seems to be the other thing I counsel patients. That's why I do get labs done every 2 weeks, because you do see a higher, more significant anemia that sometimes requires transfusions, things that we aren't used to seeing with the other TKIs. So those are the two things. And then maybe edema.